And now it's Deborah Kobylt Live.
Hi, everybody. Thanks for joining us today on Deborah Kobylt Live. Have you ever been concerned about going under the knife, mostly about anesthesia? Because I know I have been, right? That's sort of the number one concern or fear that I've had before having surgery. So today, joining us is Dr. James Cottrell, wrote this terrific book, very, very interesting book, Anesthesia Without Fear. And when I saw the title of this, I thought, okay, I've got to have him on. So thanks so much for joining us, Doctor.
Thank you very much. It's my pleasure to be here because I share your same concerns.
Yeah, in fact, I have some elective surgery that I need to have done. And I almost am putting it off because I'm thinking, oh, I don't know, I've got to go under. And that's probably the number one reason why I'm not doing it, because of that reason. But you're here to dispel so many of the fears that we have, because anesthesiology, it's a big word, is not a one size fits all. Why don't you tell us about your job? What do you do? And let's start from there.
Well, I think one of the things that you have to do is ask questions about your anesthesia. Ask
Yeah.
kind of anesthesia is available for me. Can I have sedation? Can I have moderate sedation? Can I have regional anesthesia? Do I have to have general anesthesia, which puts me all the way out and gives risk to all my organ systems?
Yeah. Let's break it down. What is the type of anesthesia where you've got the tube going down the throat and you pretty much, shut down the organs and you are doing the work for us? What type of anesthesia is that?
That's called general anesthesia, but we can also do TIVA, total intravenous anesthesia, and that's safer in a number of people if we know the history of those people.
Mm. How is it safer?
Well, it's safer if you have TIVA, then you don't use inhalation anesthetic drugs because inhalation anesthetic drugs have been shown to harm brains of babies less than 2 years of age and adults greater than 60. So you can have cognitive dysfunction after an inhalation anesthetic with volatile anesthetics. But with total intravenous anesthetics, you don't.
Hmm. Now, what happens to the body with total anesthesia anesthetics? In other words, what do you do to make sure that everything's functioning at that time under surgery?
Oh my gosh, we do all kinds of things. We take care of all your physiology. We make sure your heart's beating at a normal rate. We make sure your blood pressure's at a normal position where it should be for you and your age. We make sure that you're in the right position for the surgery and the anesthetic and not going to be injured by your position on the table. We make sure you're not awake, you're listening to what we're saying if it's a general anesthetic. But we have you not too deep, because if you're too deep, that's not good too. So we monitor your brain waves, we monitor your heart, we monitor your blood pressure, and we monitor the amount of oxygen that you have in your body. So it's a lot of things we do.
Essentially, don't you shut off sort of the nervous system, and then you end up taking over? Is that correct?
Well, what we do with the nervous system is we decrease the transmission of painful stimuli. And there are different nerve tracts in the body that transmit those painful stimuli, and we try to target those. And if we target those, then we can leave the other ones going, like the ones that control your heart rate, the ones that allow your brain to function, and the ones that keep your respiration alive.
Mm. Now, I'm going to give you an example of something. My son, when he was much younger, had to go, had to have surgery, and he went under general anesthesia. And he absolutely recalls, including the next day, that he was laying there, and there was quite a bit of pain, sort of around his eye, and his eye almost felt frozen. And I guess he was moving, and he heard, "No, James, no!" And he insists that he was, in the middle of his surgery, and he woke up. Does that happen often?
Well, awareness during anesthesia is a thing that happens, but it doesn't happen often, thank goodness. And you can have different kinds of awareness. You can feel people pushing you around. You can feel people moving your legs. You can feel people or hear people talking in the operating room, but you don't feel any pain. But then it can go all the way to the fact that you can feel the surgeon cutting you. So it can go from nothing to something. So you have to be very careful about the amount of anesthesia one gets. And that's why you have to ask the anesthesiologist if he's going to monitor the amount of anesthesia and will it correspond to a brainwave that is indicative of sleep.
There are various types of anesthesia. Can we briefly go through each one?
Well, there's the first one would be sedation, conscious sedation. And that's the kind of sedation that we use for colonoscopies and bronchoscopies and various minor procedures. And you're asleep, but we can awaken you. So it's not so deep. Then we have moderate sedation where we can't awaken you and you're fairly deep, but you're not as deep as if you were in a state of general anesthesia. And general anesthesia is when all of your reflexes are wiped out and we can't awaken you no matter what we do. And then we have regional anesthesia where we give you spinals or epidurals or block the nerve to your arm or block the nerve to your face, those sorts of things.
The spinal is a little terrifying, right? During childbirth, I had a spinal. And when the anesthesiologist walked into the room with a needle that appeared this big, I'm thinking, oh, dear Lord, how does he even know where he's putting it? How do you folks do what you do? You know, do you just sort of, go ahead, please.
Spinal anesthesia is much safer for you than a general anesthesia. Because if you have general anesthesia, you have a large stomach a large baby pressing on your stomach. It usually has acid and some food in it. And so if you get a general anesthesia, the food can come up and go into your mouth and down into your trachea. And then you get aspiration pneumonia. If you have a spinal anesthesia or an epidural, there's no chance of that happening. And that's the biggest cause of problems with deliveries with anesthesia is aspiration. So you don't want a general anesthesia for a delivery. You want a regional anesthetic.
I was surprised when I had surgery not too long ago for my knee that I guess it wasn't local, right? But what would it have been? Because I woke up very quickly. When I got home, I felt okay. I'm talking this was just a few hours, right? I went in, I had my surgery at 7:30. By 1 p.m, I was walking around at home. I thought, wow. So what would that have been that I got?
Well, it was probably a spinal. And then after the procedure, they give you an adductor canal block. It's the nerve that goes to your knee. And it's blocked and it can stay blocked for 20 hours. So, but you have to be careful because you can fall sometimes with that block. So that we want to get you out of bed as soon as you had the knee replaced so you can walk up and down stairs and get the blood flowing. So we don't use that very often, but we can.
What about folks who have to be under for hours and hours, like the 7, 8, 9, 10 hours of surgery? What type of anesthesia do they tend to get? Because that's a little terrifying to me too.
Well, that's the kind of anesthetic that we're concerned about if someone's over 60 or someone's under 2 years of age, because that's like, you've heard of fetal alcohol syndrome?
Yeah.
Well, inhalation anesthetics affect the brain the same as too much alcohol. So you don't want to give somebody a general anesthetic that long. If it's an inhalation, you give an intravenous anesthetic. We also can give we can monitor your brain waves and titrate the intravenous drugs according to that. But it takes its toll on you when you have a general anesthesia that lasts that long. You try not to have it if you can.
Yeah. What are some of the longest surgeries that you've had to monitor a patient?
Well, I think the intracranial procedures like an AV malformation, where we have to go in and try to occlude the veins and the arteries feeding the AV malformation. It's like a bag of worms in the brain, and sometimes it ruptures and keeps getting bigger. So you have to go in and try to keep those vessels closed so it won't rupture, and it takes a long time to do that.
Wow. So then what type of anesthesia would you use for that?
You'd use a total intravenous anesthetic for that. And that sometimes is better for the brain as well. So.
And that's the one where it goes down the throat, correct?
No. Intravenous.
No.
Intravenous.
Oh, you said intravenous.
Go through the vein.
Yeah, no, sorry. I didn't hear the word intravenous. I was so nervous even hearing about this. I'm thinking, oh, dear Lord. What should I ask my anesthesiologist before going under? What are the questions that a patient should make sure that they are asking?
I think you should ask him, if you're having specialty anesthesia, If you're like having a delivery, obstetrics, and you ask it, is this patient trained in obstetrical anesthesiology? You ask who's going to be assisting him, and is that person who's assisting him as qualified as he or she is, and is he going to or she going to stay with you during the whole time? If he leaves the room or she, then is somebody going to be there who's as competent to take care of you? And what kind of anesthesia is available for me? What kind is safest for me? You can ask him all those questions or her.
The thought of an anesthesiologist walking out of the room, I mean, I guess it happens, right? You know, we all think of what happened with Michael Jackson. What do you make of that? Where he was using what I get propofol, I guess, to put him out, to go to sleep. You talk about in your book, this is not sleep, right?
No, it disarms your central nervous system with the strongest drugs known to man. And then we have to reverse it and bring you back to consciousness without pain. But he left Michael Jackson, and somehow the fluid kept running, and too much of it went in. And of course, his heart stopped.
Yeah, that was such a tragic situation. But you know, I remember covering that story. I remember being there and talking about it and interviewing, you know, doctors, surgeons, anesthesiologists. And I just thought to myself, who would have even done such a thing? It was really such a tragic situation. But people need to know that this is not sleep, right?
Right, absolutely not. Well, I tell the medical students that if they come in and say, what is anesthesia? And another one says sleep. I say, well, just imagine someone having open heart surgery and they're on a cold table and you cut up in their chest and you take their heart out of their chest and then you bypass the vessels, connect it to a machine, and then you sew in the vessels and you close them back up and you use wires to close the chest with. Now, how many people could sleep through that?
Absolutely incredible. I'm going to list some different types of surgeries and tell me what you would consider the best and safest types of anesthesia. Brain surgery. Now, look, there's all kinds of different brain surgery, and I know that. But, you know, I always read, you know, that the person should be awake. Is that necessarily true? What type of anesthesia do you use for that so that they don't necessarily feel anything, but they can still speak back?
Well, I think the safest way to do like a brain tumor that's pressing on the motor area, which controls your arms and legs and feet, then you need to, you actually put them to sleep until you get all your instruments and monitoring equipment in place. And then you awaken them when the surgeon gets down to the area that they're going to operate on. So if you're close to the motor area where the leg moves, then you ought to be able to stimulate that leg and see if it will still move after the surgeon does this. So we need that to monitor the patient with, and it's much safer for the patient.
Wow. Okay, you mentioned heart surgery, open heart surgery. What type of anesthesia, in your experience, is best for that?
Well, you have to be someone who's trained in open heart surgery. So that's a year of extra training plus usually 6 months in learning how to use the echocardiogram or the special monitor for the open heart surgery program. But that's a total intravenous anesthetic that should be used because open heart surgery patients, if they're on bypass, they have low perfusion pressure. And so you don't want an anesthetic that might damage the brain. You want an anesthetic that might help the brain. So you'd use an intravenous anesthetic drug for that procedure.
Gallbladder surgery. I'm just listing them off here. You got to have your gallbladder taken out, which I guess generally is a pretty easy and common procedure these days. What type of anesthesia for that?
Yeah, I think that would require a total intravenous anesthesia with an endotracheal tube because you wouldn't be able, it's very high up you could do an epidural, but then the patient might have difficulty breathing. So it's probably better to have a total intravenous anesthetic for the gallbladder.
Yeah. Yeah, that makes me nervous when I hear about the tube going down the throat. Do you sometimes have issues with that?
Yeah,
I've had that surgery. I've had that surgery and I wake up and I'm in pain. I feel like I can't breathe. What's that about?
Well, that's what we ask the patient. You need to tell your anesthesiologist beforehand if you've had surgery before and if the anesthesiologist has had trouble with your airway. if you've had trouble breathing with an endotracheal tube, or if they weren't able to place the endotracheal tube. Sometimes they place a tube that's too large for you and causes your throat to swell afterwards, and that would give you the feeling of shortness of breath. So, but hopefully the anesthesiologist you have will choose the right size tube based on your weight, your sex, and previous experience.
Oof, plastic surgery. That's the big one, right? I mean, I know
Right.
so many people and they're going to, have their stomach sort of tightened up. And I think, oh boy, that looks good to me. But I'm telling you, I won't do it because I'm because of the anesthesia. Talk about that because that's kind of a lengthy procedure, isn't it, to go through?
Well, I think there have been a number of deaths for plastic surgery, repair of stomachs, the suction of fat from the stomach and from the thighs and things like that. Generally, they have used local anesthetic like xylocaine, and they use too much, and too much causes the heart to stop. So you really need someone who's good at giving anesthesia for plastic surgery procedures and knows how much drug they can give and how much they can't give. It can't be just a circulating nurse handing drug to the surgeon and he injects it into the area. You really have to have someone who knows what they're doing. And don't go to these clinics that you see advertising, do your plastic surgery here, because you're probably not going to get what you need or what you want.
Yeah, well, if anybody wonders why I still have a little pouch, that's why. I just don't want to do it unless the surgery is absolutely necessary. I'm not going under because that is concerning. How do you even know who you're selecting? They seem like they're reputable. They're in one of those fancy, nice towers, here in Los Angeles, for example, in Beverly Hills. But then you think, gosh, do they have the right people working with them? And often they're in those surgery centers. Are those surgery centers just as good as going to a hospital? Are they just as equipped?
Well, I think if you have medical conditions other than what you're having your surgery for, you should go to a major medical center to have that done. Because if you have heart disease and you're having your cosmetic surgery on your face and you have a heart attack during the procedure, there's no one around to help take care of you. They can't call someone from the other part of the hospital to come and help with your operation. So it's safer to go to a major medical center. If you have cosmetic surgery on your face, what they do is give you sedation at first while they use local anesthetics on your face and then wake you up. And they do most of it under local anesthesia because you don't want a tube in your mouth because it distorts your face. So your facelift wouldn't look as good.
Yeah. Oof. It's all a little scary to me. Talk to me about your career. Why did you even get into this? It's really a very interesting field in medicine.
Well, I think once when I was small, my father got lung cancer, and very little they could do for him at the time. And so during his prolonged period before death, he was given a lot of morphine for the pain, and that simply made him sick and vomiting and nauseous. And I thought, well, there's really got to be a better way to control pain than that. And then not long after that, I got a bunch of glass in my foot, and the surgeon used ethyl chloride on my foot to dig around to get all the pieces of glasses out. And I thought, well, there's got to be a better way. So I went into anesthesia because it's, without pain. And one day I saw an anesthesiologist come in, and the patient got into real trouble with the surgeon giving sedation, had a cardiac arrest, and the anesthesiologist saved the patient. And I thought, my goodness, it's a wonderful way to relieve pain for chronic pain problems. And it's a good way to help people survive when they have to have that dreaded anesthetic for their conditions.
Yeah. Talk to us about relieving pain, because a lot of us don't realize that that's part of the big part of the job too. Not just putting us under, but relieving pain after. Talk to us, please, about that.
Yeah, we do. We have a pain fellowship after anesthesia, but you can also do it after neurology and psychiatry. And you learn all kinds of ways to take care of pain in people with cancer, people with chronic pain problems, and acute pain problems. So specifically trained for that. And there's all kinds of ways. People shouldn't suffer pain, especially someone who has pancreatic cancer and is dying, or cervical cancer and is dying. we can do all kinds of things to keep that pain from bothering you as you pass on to another world. So I think it really helps prevent a lot of assisted suicide if you have a good pain management doctor.
And of course, that pain management doctor would do that only in a hospital or a designated facility, right?
Right. They have pain management clinics that are approved by the American Pain Society and different societies that do nothing but regulate pain procedures. So if you have low back pain, you can do a lot of things for low back pain. Exercise is probably the first thing you want to do. And then you go for acupuncture, and you can go for mindfulness. Then if you have to, you can go for blocks, do 2 or 3 blocks with local anesthetics and steroids. And then you can actually go for surgery after that. But you try to avoid surgery because it doesn't always make it better. The other things we do make it better.
Yeah. So basically, when you go to a pain center, you're seeing an anesthesiologist.
Right. Or a neurologist or a psychiatrist that have been trained in pain management. Yeah, but make sure you get someone who's certified in pain management. They're certified by the American Board of Anesthesia.
Yeah, let's talk about women's health, birth, hysterectomy, all sorts of things like that. How do you work, with women and helping with their pain?
Well, that's also a separate subspecialty in anesthesia. So you have to have an extra year. You should have an extra year of training in obstetrical anesthesia. So you learn how to manage not only the non-complicated cases, but you manage people with preeclampsia, you manage people with triplets or twins. You manage anatomical deformations in the babies as that you try to get them out, and you take care of the preeclampsia, the hypertension of pregnancy, the full stomachs. You just really got to be on top of everything, even though the father sometimes or the significant other is sometimes in the room with the patient.
Yeah. Gosh, doctor, it's so interesting. Tell us about your career and, some of the cases that really stand out in your mind, where you helped people, saved people, and you learned something that you pass on to students, that you pass on with your patients to help them, would you?
Well, I started my career at New York University here in New York City, and I was in charge of neuroanesthesia. And that means that we monitored all the cases that came in for brain tumors or head trauma and tumors, brain tumors, head trauma, aneurysms, and AVMs, as I said earlier. So I learned a lot I published early on about the effects of anesthetics on cerebral blood flow, and it causes the brain pressure to go up, which is bad for the brain. So we learned all those things about certain anesthetics and also about the vasodilator drugs. And as we learned those things, we stopped using them. We even learned a muscle relaxant causes increases in intracranial pressure and can cause damage to the brain. So there's a lot of things that we learned in neurosurgery when I was in my early days in anesthesia. And I continue to do that when I went to my other jobs. And then we do research on memory now and what happens to the brain with anesthetics and memory and what causes the cognitive dysfunction. So that's what we're trying to look at now.
Any parting words that you would like to share with our audience? Because while I did read your book and go through it and made my footnotes, there are things that you could share with our audience that I might not even know to ask you. Would you?
Well, I think the biggest thing is when you go, ask for a pre-op visit. Say, I want to meet with my anesthesiologist. And you share with that anesthesiologist your fears. And you share with the anesthesiologist what drugs you're on, because they all affect the anesthetics that are used. What drugs you're on, what procedures you've had before, if you've had any difficulty with anesthesia. And then, of course, ask the anesthesiologist their qualifications. Are they qualified to be an obstetrical anesthesiologist? Are they qualified to manage your severe pain you have in your right leg? Are they qualified to manage your 2-year-old? Because those are very dangerous cases. Pediatrics is very difficult to do. So you got to ask the questions of your anesthesiologist, and of course, are you going to be with me throughout the whole case? And if not, will somebody competent be with me? That's very important to ask.
I will tell you, though, very often a surgeon, when you ask for that information, they'll say, oh, they'll call you the night before. And then I'll say, well, who's calling me the night before? Someone in the group. Well, who? And sometimes it's really difficult to get that information from your surgeon because either they don't know, right? And then in which case you're a nervous wreck. It's the night before surgery. You're getting a call at 8 at night. And half the time I forget my questions. Even if I write them down, I even forget to ask them. Do you see what I mean? Like the surgeon also has to know that. Go ahead. Go ahead.
That's another reason why I wrote this book, because the public needs to know that they can ask for a consult with their anesthesiologist before the anesthetic. So you can request that, a consult. They get paid for consults. So they should be able to do them. Yeah.
Very, very interesting book. And I really appreciate you coming on. What about the future of anesthesia? What are they working on to make it easier, better, safer, all that stuff?
Well, I think the future looks bright. We've come so far. You know, the deaths from anesthesia have decreased from 1 in 2 or 3,000 to 1 in 250,000. So we made a lot of progress. Now we're trying to save people from having memory disorders after anesthesia and surgery, and children from having behavioral disorders. We're looking at the ways to induce anesthesia without drugs, say a magnet or an electrical current. And we're looking at feedback loops that show when pain is being transmitted and what we can do with a local anesthetic to stop that transmission. So I think in the future, we're going to have lots of things, and we'll avoid many of the complications, the potential complications that we have now. So
wonderful. Thank you for doing all that. Thank you for coming on our show and sharing with our audience, you know, just to sort of put some of their fears at rest. You know, it's a good thing to have this information. Sometimes a little too much information makes me a little nervous, but you know what I mean. But you've managed to subside that. And my big takeaway is people go ask the questions. Don't be afraid to ask them. And it can be intimidating because those surgeons will say, they'll call later tonight. It's like, oh, okay. But you have to continue to ask those questions. And I like what you said, ask for a consult, because that is part of the work and they get paid for it. Go ahead. You were going to say something.
Right. No, I think you shouldn't be afraid. You should ask the question so you won't be afraid. And don't go to the operating room in the morning and say, just put me out. I don't want to know anything. Well, that's just asking for trouble. Get your information before that time.
Yeah. What about surgery centers? I know we did touch upon that. I know we did, but there's a lot of them. Like even if you have to have your appendix out, or like we mentioned, the gallbladder, they very often are not done in a hospital anymore. What if something goes wrong? Right. Like, should you insist that you have it done in a hospital or not? I mean, sometimes they don't even have the time or the room or anything. Go ahead.
The surgery centers are regulated by different national organizations, and they try to make them as safe as possible. But we only do patients that are ASA1. That means they're in good physical condition. We don't do them above ASA3s, because then you start to get into all the medical problems in ASA3s and 4s and 5s.
Right.
So you don't do 5s. So if you're a sick person with a lot of comorbidities, you do not want to have your surgery in an ambulatory surgery center, except if it's a cataract, and maybe not even then, because cataract is usually local anesthesia.
Okay, a lot to really think about, people. A lot to think about.
Yeah, read the book. Read the book.
That's what I was going to say. Pick up the book, Anesthesia Without Fear. When I first saw it, because your publicist she's quite terrific. And she sent this to me and she said, Deborah, I know you. You're going to find this really interesting. And I thought, And I read through it and I thought, oh, this is fantastic. Then I was talking to my friends about it and everyone was suddenly interested. We had to, we're at a dinner and everyone was talking about the book because we all at one time or another end up going under. So what a terrific book to read so that you're more knowledgeable about what could happen. And then you know the questions to ask. So please pick up the book, Anesthesia Without Fear by Dr. James Cottrell. Doctor, thanks so much for joining us today.
Thank you very much for having me. I appreciate it.
Yeah, very interesting. And everybody, you could find our interview with Dr. James Cottrell on YouTube, on Facebook, on Instagram. And then, of course, as an audio podcast, you can find us on iHeartRadio, Amazon, Apple Podcasts, anywhere you get your podcasts. Just look us up, Deborah Kobylt Live and Dr. James Cottrell. I'm your host, Deborah Zara Kobylt.